My name is Dr. Nathan Wong, Professor and Director of the Heart Disease Prevention Program at the University of California, Irvine, and also the past President of the American Society for Preventive Cardiology. It's a pleasure to be here at the World Congress on Heart Disease, and my talk yesterday was on cardiovascular risk assessment and the latest guidelines. So preventive cardiology involves several different steps, and the first of which is assessing the patient's risk of cardiovascular disease. And prior guidelines have involved use of the Framingham risk scores for predicting the risk of coronary heart disease. The new American College of Cardiology, American Heart Association guidelines released last November call for the use of the pooled cohort risk scores for an estimation of 10-year risk of atherosclerotic cardiovascular disease as the first step in risk assessment. And these scores differ from previous ones in that they estimate the risk of non-fatal myocardial infarction or fatal coronary heart disease or non-fatal or fatal stroke. So they are more comprehensive in that most prior scores have really just focused on coronary heart disease. It's important to also note that these risk scores were based on a much larger cohorts of individuals, actually 4 major U.S. prospective cohorts of adults totaling more than 25,000 individuals, including persons from the Atherosclerosis Risk and Community Study, the Cardiovascular Health Study, the Coronary Artery Risk Development in Young Adults Study, as well as the original and offspring Framingham heart studies. So they have also been recently validated in the REGARD study and provide a reasonable estimation of a person's 10-year risk of atherosclerotic cardiovascular disease. Importantly, they also provide estimates of an individual's lifetime risk of cardiovascular disease. This can be a very effective motivator, particularly if the 10-year risk might be low. The lifetime risk is oftentimes much higher, perhaps in the range of 50% or greater. Now, one of the other statements made by the guidelines is that if the decision to treat or involving statin treatment or other preventive treatment is uncertain based on the person's global risk assessment. So current guidelines, for example, recommend in a person without coronary heart disease that if the 10-year risk is 7.5% or greater, then the individual is potentially suitable for statin-based therapy. Now, this is not an automatic decision. The risk score really needs to be the impetus for a risk discussion between the clinician and the patient, so there should be a discussion about lifestyle management, potential risk versus benefits of statin or other preventive therapy, and really a discussion about other pros and cons about starting or intensifying therapy. However, if the the decision to treat is still uncertain, then one could consider other tests. If the person has, for example, a premature family history of cardiovascular disease. So for example, a heart attack or stroke under the age of 55 in a male first-degree relative, or under the age of 65 in a female first-degree relative, or if they have, for example, an elevated C-reactive protein defined in these most recent guidelines of 2 or higher, or a coronary calcium score of 300 or higher, or greater than the 75th percentile, or an ankle-brachial index of less than 0.9, indicative of peripheral arterial disease, that if any of these are present, they can help potentially risk stratify the individual to a higher level of risk, and therefore help and actually better inform that treatment decision. So these are the main points that were raised in the new ACC-AHA guidelines for cardiovascular risk assessment, certainly with continued research involving other tests and their significance for predicting cardiovascular disease. It will be of interest to see how these guidelines evolve over time to potentially consider the use of other tests that might be suitable for further enhancing our ability to accurately capture the person's cardiovascular risk. So really in summary, we're starting with a actually global risk assessment using the pooled cohort risk equations. We then have to consider a person's family history, whether they have other characteristics such as metabolic syndrome or elevated biomarkers such as C-reactive protein, and certainly there is the place for considering whether somebody has an increased calcium score or low ankle brachial index for further stratification of risk.